Greetings to all. Welcome to the another session of Physio TV. Today, I, Dr. Twinkle Kundani, Assistant Professor at Neurophysiotherapy Department at Sanjeti Institute for Orthopaedics and Rehabilitation College of Physiotherapy, will be taking a session on ICF and pediatric rehabilitation, clinical application, and problem solving. So the main objectives for our today's session will be that the learner will be able to learn about the application of ICF framework in pediatric rehabilitation and will be able to develop problem solving strategies for overcoming challenges in pediatric rehabilitation using ICF. So, starting with the topic, how does a physiotherapist play a role in not only improving physical health, but also enhancing the overall quality of life for our patients? So, as a physio, when a patient comes to me, being a pediatric therapist, the parents are always worried that my child is not able to walk, my child is not able to sit, or maybe he's not able to go to school. So as a physio, I'll just not focus on the physical aspect of the patient, but I need to also focus on the what parents are going through, what is the emotional status of the parents, what is the social involvement of the child, what is the overall participation of the child. So as a physio, we just don't focus on the physical health, but we focus on improving the overall quality of life. And quality of life has the domains of physical, psychological, as well as the social domains, including the overall development and including the overall quality of the child when it comes to include involvement of the specially able child into community. So what is ICF? ICF is International Classification of Functioning, Disability and Health. It has come a long way from ICIDH, that is International Classification of Impairments, Disability and Handicaps. So in this, we can see the ICF has made a major change from disability, handicap, impairments to ICF, that is International Classification of Functioning. So now the ICF has started putting ability first rather than disability. So it is a major shift. So it focuses on the biopsychosocial model integrating medical and social perspectives. It was approved by WHO in 2001. It has come a long way from ICIDH, as I already explained. The focus is now shifted to functioning domain from disability domain. So, how is ICF different in pediatric rehabilitation, or why is it important to incorporate ICF when it comes to pediatric clinical application? So, in pediatric rehab, ICF allows me to have a holistic assessment. Using ICF, I'll not just assess the physical impairments of the child or the physical strengths of the child, but I also assess the other factors like the activity level of the child, participation level of the child, what environmental factors are affecting or maybe either helping improve the participation level of the child. I'll focus on the strength of the child, the strength of the parents, that the whether parents are involved in the rehab, whether parents are motivated. So it helps me give a holistic assessment. I'll include a case study at the end to show how the holistic assessment is done using ICF, and it helps us guide or maybe help us plan for the future intervention, because when it comes to pediatrics, the major challenge that we have in pediatrics is it's a lifetime approach, and it has a dynamic changes over time. So the key differences in pediatric ICF application is growth and development considerations, because when we start seeing child starting from an ICU, that is early intervention, till the child is completely grown up, or maybe in certain conditions like cerebral palsy or say some sort of muscular dystrophies, those are the lifelong involvement or the lifetime disabilities that the child will have. So the major difference is we need to consider growth and development when incorporating into ICF. So those will have dynamic changes over time, especially when it is the phase of puberty or adolescence, or when there is a transition from pediatrics to adulthood. So developmental milestones impact functioning. So we all know that when it comes to cases like cerebral palsy, especially CP or any long-term disability, The impact of growth spurt or impact of adolescence is highly seen in cases of functioning, like the during growth spurt, if the child is already a diplegic, having crouch, the involvement or the crouch may increase during growth spurt as there is muscle and bone length alterations. So it is very important to consider ICF, and it gives you that perspective. So ICF also allows us to have the influence of family and environment. When coming to pediatric rehabilitation, not only just the child, but the entire family, the entire social aspect of the child is important, because ICF again gives us more vision, or it gives us more clarity to incorporate participation level of the child. So school and community integration is the main motto or the main purpose. So anytime the child is coming to me or the parents are visiting me, the first question is, when will our child walk and when will our child be able to go to school? When will our child be able to play with the other peers or the other children of same age group? So this is participation of the child. So ICF helps us develop the school and community integration as well. So coming to the domains of the ICF, first important thing is the health condition. It is the diagnosis. So it is a disorder or the disease. So in health condition, example, when we have a case of cerebral palsy, or say a child with neural tube defect or DMD, so those conditions will come into the health condition. Coming to the further classification, first thing we focus on is the body function and structures. Body function and structures are the major impairments. I have included examples and case studies in the further slides. So I'll cover these things in detail in the further slides. So in impairments, in functional and structural impairments, it could be reduced range of motion, reduced endurance, maybe lack of coactivation of the postural muscles to maintain proper posture. Everything will come under function and structure. At structural level, maybe the impact of hypoxic ischemic encephalopathy that the child is having, that is seen on CT scan or MRI, will come under the structural impairment. Coming to the important part, that is the activity, which means the capabilities and restrictions in the functions that the child is having. So activity is anything that you are doing alone. Example, eating, maybe sitting, walking, dressing, grooming, bathing, toileting, everything comes under the activity aspect of ICF. Coming to participation, participation is anything where apart from you, some other person or few more people or children are involved. So participation at pediatric level or at a child level is mainly play, going to school, going to garden with friends, maybe going to time zone with friends and family, going for shopping, everything will come under participation level. So ICF helps us give what amount of activity and what amount of participation the child is able to do or is having, and help us focus or maybe plan intervention for activity limitations and participation restrictions that the child is having. Apart from that, when it comes to any sort of movement or any sort of activity or participation, it is not just the child that is involved or not just the individual who is involved for the activity. It also has two other important domains. One is the task itself, what the child is doing, and second is the environment. So environment, when it comes in pediatrics, maybe if I have a case of cerebral palsy, who is a child who is a quadriplegic CP, maybe the child is not able to walk in the community because we don't have the railings, or because maybe the child is not having the elevator facility available, which is restricting the participation of the child. So assessing not only the physical but also the environmental factors becomes very important when it comes to pediatric rehab. So environmental factors will have things like housing, sanitation, workplace conditions. So here in pediatrics, the workplace is mainly the school, or the community where the child is going with the friends, like on playground or at parks, etc. Apart from this, personal factors, ICF gives us that understanding, keep focusing not only on the negativity or focusing not only on the impairment, but also on the positivity or the child. We usually, when the child or mainly the family, when they approach me, they usually forget about the child. They are so tensed about the condition that my child is having cerebral palsy that we forget to look what the child is having. So personal factor assessment helps me with developing my treatment strategy, focusing on what are the strengths of the child. Example, if child is diplegic, where upper limb functioning is normal, that time the strength could be that the child likes to paint, the child likes to draw, child is going to a normal school, is able to maybe in schooling activities, he's able to cope up with the other peers for writing, for drawing, for painting. That becomes a strength of the child. So using ICF, I focus on the strength of the child mainly rather than on the impairments of the child. So in personal factors, it helps me with the assessment with what beliefs that the child is having. Maybe in pediatrics, it is mainly whether the child is a happy child or whether the child is a cranky baby, is continuously crying, is having some sort of arousal issues. The child is not able to pay attention when I am taking the session. All these factors will come under personal factors. Important part to consider when you're using ICF in pediatrics or in any other specialty also is every functional activity may not be a participation ability. Real challenge of us as therapists is converting function into participation, because being a clinical therapist more, we focus on getting the child back to community, which involves participation. So maybe at my therapy session, the baby is able to eat or feed himself, but going back at his home or maybe at a dinner table with his family, he is not able to eat, becomes my participation restriction. So, us as a therapist, we should focus mainly on the participation level of the child rather than on the activity level. So, in ICF model, examples of impairments, that is the body structure and functional impairments, could be excessive stiffness, reduced range of motion, decreased ribcage mobility, decreased coactivation of abdominals and glutes, and poor visual acuity. Some other structural impairments could be presence of some contracture at knee or at ankle, maybe plantar flexor contracture, presence of scoliosis, presence of complete ischemic insult at your brain level, which is relevant in CT or in MRI, everything will come under the structural and functional impairment. Individual functions, that is the activity of the child, will have examples like cannot transition or transfer himself from a wheelchair to commode back to the bench in school, or maybe the child is not able to speak clearly, he cannot bite solid foods, he cannot play, cannot play alone will be an activity, that is maybe cannot play alone, maybe using ring stacker or just drawing something will be an activity. Social functions are the participation. So participation restrictions examples could be the child cannot play on playground with friends. He is not able to play board games with friends. These things becomes the participation restrictions. He is not able to participate in play activities at a birthday party. He is not able to communicate with others. This becomes a major restriction when it comes to pediatrics, not able to communicate with others. Coming to the contextual level or the contextual factors, in this you have the environmental factors as well as the personal factors. So environmental factors could be that the stairs are not available at home, there are no ramps available at school or malls. Maybe those factors are limiting his participation. Use of washrooms, and if suppose example the child is having commode at or western toilet at home, but when it comes to transition at school, he's having Indian toilet system, which is again affecting his participation. These factors will be environmental. At personal level, maybe the child is cranky, he's moody, his attention span is very less, becomes the major barriers. So here are some examples of activities and participation. So in this baby is playing alone. He's playing with the rings. So this becomes an activity. This again, he is eating his food alone, becomes an activity. But same activity, when the child is able to eat the food in a family setup or on a dining table with his family members, this becomes a participation. So anything where you're alone becomes an activity where you or the child along with two, three other people becomes a participation or a social activity. Now coming to this example. So here again, cycling with friends becomes participation. Cycling alone becomes activity. So these were few examples to get clarity between activity and participation. So anywhere you are where you are alone or the child is doing activity alone becomes activity. Same thing when done with a group of friends or maybe in community becomes participation. So last example here, raising hand is an activity, but same thing when done in class, maybe raising your hand to answer the question asked by teacher, that is to communicate, becomes participation. So coming to an example of case study. So taking an example of 8-year-old quadriplegic cerebral palsy. So body function and structural impairments could be reduced mobility in lower limbs, excessive stiffness in lower limbs, impaired somatosensory function, femoral anteversion. If the child is quadriplegic, he may have scoliosis. Everything will come under body function and body structure. Coming to activities, in activities, abilities, that is the positive findings could be, or the plus points of the child could be that the child is able to ambulate with the posterior walker with moderate assistance. Maybe he is able to go from one room to other at his indoor setup, or maybe going from one classroom to other in school setup becomes activity. He self feeds independently is the activity ability that the child is able to do. Coming to limitation, he doesn't stand independently. He cannot ambulate without an assistive device independently, becomes the limitation of the child. Coming to participation aspect, he participates in school independently, ambulating within the class using walker is the participation level of the child. He is able to do, but here he is doing it with his friends besides. So this becomes in participation level. He participates in singing competition in school, becomes again a participation thing. Maybe if a child is able to participate in drawing competition, maybe he is able to maybe he's able to just use his motorized wheelchair alone and go out with his friends, becomes a major participation of the child. Participation restrictions, cannot play in standing independently with his friends, unable to play games at birthday party becomes a participation restriction. After this, when we use ICF, we need to do a detailed examination or a detailed assessment, or we need to ask detailed questions related to environmental factors. So facilitators could be that the parents are motivated. There are ramps available at home. There could be other and a major environmental facilitator is that the child is having a sibling or he stays in joint family where he is seeing his brother or sister, and the siblings are also helping him participate in his play activities at home, becomes a very major important facilitator. Coming to barriers, maybe stairs at home, ramps in school are not available, that will again affect the participation level of the child, affecting your overall quality and overall involvement into the community. Coming to personal factors, facilitator may be that the child is motivated and playful. Again, a very important facilitator could be if the child is cognitively normal, he is able to understand what you're telling, he is able to register, he is going to normal school, becomes a very important personal factor or a personal facilitator for the child. Personal barriers, as it's pediatrics, sometimes the child may be stubborn, the child may have behavioral issues, may lack attention, he's having problems with maintaining attention for more than 10 minutes, becomes a very important barrier because you need to plan your treatment likewise. So, this was an example of how ICF is used for assessment, or how do we use ICF to get the entire detailed thing about the child. As we know, ki when it comes to participation or when it comes to any sort of movement, movement emerges from task, individual, and environment. And ICF helps me assess all the three domains for the child. Apart from that, it also helps me assess what are the strengths of the child, what are the strengths of the parents, what are the environmental factors which I can use to maybe help me with the treatment, or which I need to modify to improve the participation of the child. Coming to clinical problem solving using ICF. So, how is ICF used? Yeah, why do we use ICF for decision making? So, as we have already seen, it helps us give a standardized framework for assessment and treatment. Depending upon the assessment, say for example, in this case, we know that the major participation level was he was not able to play in standing, or maybe he was not able to go with his friends in from classroom to playground, could be a participation restriction. So I can make that thing as a goal, and I can plan my treatment likewise. So when coming to treatment, I know the ramps are not available. I can get those environmental modifications done to improve the participation of the child. Maybe I can suggest that the parents need to take motorized wheelchair so that the child can operate his own wheelchair and go out with his friends, improving the participation of the child. So it also helps me give a clear idea whether the goal that I have made is feasible, whether the goal is achievable, whether if I'm keeping a goal, which are the domains or which are the primary impairments that I need to focus on, be it physical impairment, be it psychological impairment, because sometimes the child may not have any sort of physical impairment, that the strength may be normal, the sensory functioning may be normal, but the child is not motivated. So that time I need to think of maybe getting a psychologist into the treatment aspect, where he is helping the child to come out of whatever mental issues he is having and improving the participation of the child. So ICF helps me give a standardized framework for assessment as well as for the treatment of the child. It helps me identify barriers and facilitators. So barriers which I can improve, facilitators, those becomes my strengths to form the management for the child. It helps me form smart goals using ICF components. So example, goal, when it comes to pediatrics, the goal, or when it comes to entire physiotherapy, our main motto is to get the patient back to community, or the social level of participation is very important. So goals in pediatrics always need to be participation related, or at least activity related. So, example, here in the same case that we discussed for ICF assessment, so how can we form a goal so that a child will be able to walk 20 steps with the help of walker and go to school from school gate to class in 2 minutes in next 3 months. So this becomes my goal. So entire goal is focusing on the participation level of the child, going from school gate to the classroom with friends in 2 minutes in 3 months is participation. So major goal that we form in pediatrics are participation related goals. It could be that the child will be able to feed himself using a spoon sitting on a dining table with his family members becomes a participation. Child will be able to play board game activities with his sibling, maintaining correct posture, and will achieve this goal at the end of 3 months becomes a participation related goal. So this becomes your main goal or say long term goal that we need to work on, and it will have many short-term goals. So in this example, so here we can see the major impairments were that the mobility in the lower limb was reduced, the somatosensory function was affected, there was say example the femoral anteversion was present, or say that the child strength and endurance was lacking. So our short term goals could be formed in that manner. Maybe we need an orthopedic surgeon to come into our team here, where femoral anteversion, if the child needs an operative or a surgical procedure for the same, we can get orthopedic surgeon's opinion, so it will help me with that. Other thing could be, second goal could be that somatosensory function was affected, so I'm improving the proprioception by giving close chain activities, by giving mid-range isometrics. I need to improve the strength and the endurance of the child becomes my third goal. Improving postural control could be my other goal. Along with the goals, I need to also see that the environmental modifications are done likewise. So when the child is going from school gate to classroom, we can see that the classroom of the child is on the ground floor itself, so that the stairs are not affecting the participation of the child. Or maybe if a child is not able to say feed himself because the height of the chair is too high and he is not having that good control ki he is able to bend and eat, so maybe we can reduce the height of the chair to the table level so that he can sit properly with complete support and he is able to feed himself, to improve his participation for feeding at a social gathering, or maybe eating when you're sitting with your family on a dining table. So this is how ICF helps me form smart goals, and it helps me improve the treatment also of the child, or to plan the treatment. So, example of the goals, we have already seen that it always focuses on improving the participation, and ICF helps me link goals to activity and participation and not just impairment. Means when I am using ICF, I can incorporate ICF for participation. Otherwise, we'll write goals like to improve range, to improve balance, but why are we improving it? To improve the participation of the child. So ICF gives us a clear idea about it. So we have seen that ICF helps us plan the management for the child, or ICF based intervention planning is important. So intervention focus areas to improve the participation of the child, that is the functional training level. So we have already seen that the main goal was participation related, and the short term goals were mainly on activity level, that is improving postural control, improving somatosensory function, improving balance, improving say range or endurance or strength becomes the activity level goal, that he'll be able to sit and maintain the posture becomes an activity. He'll be able to sit, maintain posture, and talk with the sibling becomes participation. So the main goal is participation, but we can break down our short-term goals focusing on the functional training, that is the activity level. We need to, if needed, we can incorporate environmental modifications. We can have family and caregiver training, because we have already seen that in pediatrics using ICF, and apart from it, the parents play a very important role. So incorporate looking at how the parents are, whether they are motivated or they need some sort of training. We can also train parents for those things. We have seen if the child is having some sort of psychological issues or mental issues, we can get a psychologist in our team. If a child is having femoral anteversion or some sort of deformities, after assessment we come to know, we can incorporate a pediatric orthopedic surgeon, or maybe we can incorporate a OT to improve hand function more. So ICF also helps us give a interdisciplinary team collaboration. So thank you. This was about how ICF is used in pediatric rehab for problem solving, as well as how ICF is used for assessing a patient and maybe for forming goals for future. So at the end, I would like to thank Sanjeti Institute for Orthopedics and Rehabilitation College of Physiotherapy and Sanjeti Healthcare Academy for giving me this opportunity to share my views. And I would like to thank all the viewers for joining. See you all at the next session of Physio TV.